Welcome, Wisdom Warriors, to today's huddle. Topic of the day, spinal motion restriction in patients 65 and older. Here's a few of our facts. And we know these things. We know that falls happen. We know that gravity wins. And oftentimes our patients who have falls are going to be the older generation. Today I want to focus on our T1, General Trauma Management, Spinal Motion Restriction, and I really want to focus in on our patients that are 65 and older. So, first we need to ask ourselves, when we're going down our protocol, we're looking at mechanism indicating a high risk for spinal injury. Yes. Now we're going to follow down our boxes. Does the patient meet any of the following criteria? And we're trying to talk about the line here where it's 65 and older. So, why are we putting falls, or why should we put falls in a category in our minds and in our assessments that links to high risk mechanism for the purpose of spinal motion restriction using a collar only and without a backboard? Well, let's look at some of our factors. 17.7% of adults 65 and older have been diagnosed with osteoporosis, and it's more common in our female patients than in our male. We know that bones become more brittle, they become less dense, even with the natural aging process. And specifically, I want to look at the vertebrae in the spine. How are we going to do this? Well, let's talk about hyperflexion and hyperextension of the neck. So starting with hyperflexion, this is when your neck is forced forward beyond its normal range of motion. Think of your patients that have a fall and they hit their head on the way down on something like a counter, a chair, a desk, any of those things that cause that rapid forward motion of the neck. This can cause injury patterns of cervical compression fractures as well as flexion tear dot fractures, and this will cause damage to the underlying ligaments, which also can lead to spinal instability. On the flip side, we're going to talk about hyperextension. This is when the neck is forced backwards beyond its normal range of motion. This can be caused by things like falling out of a wheelchair, hitting your face on the ground, a fall from standing, falling forward, and you'll see a lot of facial trauma that goes on with this. And these can cause injury patterns that lead to C2 fractures. So this x-ray is showing you what happens in the neck during a flexion and extension of the neck. And these are a normal range of motion, flexion and extension. So as you look at the vertebrae and as you see them sitting on top of each other and you see all of the little processes that are there, you can picture in your mind what would happen if this happened with a sudden deceleration type force, causing a whip of that neck one way or the other. And now I'm going to give you a few facts. I want to put this into your arsenal of knowledge so that when you're going to assess these patients, you have some of these things in your mind. I'm not going to read them all to you because you're sitting and looking at the same slide that I'm sitting and looking at, but take a moment to read through these points and make it part of your understanding of why falls need to be considered a high risk mechanism for spinal injury, especially in our older patients. So, what's our goal today? We're going to increase our index of suspicion. We want to do some spinal motion restriction without a backboard on our patients that are 65 and older that have had ground level mechanical falls. So when you're assessing and you're treating these patients, you need to have this in the back of your mind, all of this kind of information that's put forward, and help you to decide whether or not to place a C-collar on these patients. It's more than just talking to your patient and assessing, do you have neck pain? Do you have back pain? Do you have numbness and tingling? We all know those questions. We ask those questions. We will ask them without a thought every single time. But what I also want you to consider when you're going through this assessment is thinking about how the mechanism of the fall can cause internal damage and the possibility of cervical spine instability or fractures. Oftentimes, these patients have distracting injuries. We all know that facial wounds, scalp wounds, they bleed, and not to mention the worry that comes to these patients that's associated with having a fall. And both of these things can lead them to be distracted and maybe not give you all of that information in the beginning of your assessment to clue you into maybe, oh, they're having pain, I need to put them in a collar. You know, you think about the mechanism of a fall, somebody like me that falls, I got a little more cushion to fall. You go out on grandma who's on the linoleum, you know, she tends to have slightly brittler bones. And just due to the aging process, that mechanism definitely should clue you into maybe I need to take a more thorough look at this neck and the mechanism and decide to put this person in spinal motion restriction until it can be cleared with a CT scan. I want to thank you for your time today. Came out and you listened to my huddle. I'll let you know when I've got more topics coming up. But my goals today were to talk about spinal motion restriction in patients 65 and older, the mechanisms that could clue you into maybe needing to put a collar on them per protocol, even though they're not complaining of neck or back pain, but because of the mechanism involved in their injury. I hope this gave you some food for thought, and I'll talk to you guys soon. Thank you.